Uh, good afternoon, good morning, good evening. It depends on the time zone. My name is Jolanta Małyszko. I really have a pleasure today and honor to be a moderator of this e-seminar, which is organized by ERAKI working group, which I am a part of the board member. The title is very exciting: AKI in cancer patients, advances in onconephrology. And together with me, there are world-known specialists in the area, starting with the panelists. The first one is Professor Shruti Gupta, a professor at the Division of Renal Medicine and director of Onconephrology and assistant professor in Harvard Medical School. She leads epidemiological, translational, interventional studies related to the nephrotoxic effects of cancer therapies, as for instance, novel biomarkers and therapeutic targets of cisplatin or immune checkpoint inhibitor or methotrexate-associated acute kidney injury, myeloma-light cascade nephropathy. And what is really important for together our meeting is fact that Dr. Gupta was one of the founders of the American Society of Onconephrology and now is the president emeritus of this society. Together with us is also Professor Victoria Metaxa, and she's critical care and major trauma consultant at King's College Hospital in London. Her major interest is bioethics and end-of-life care in ICU. She also leading the critical care outreach team of the Trust. And lastly, but not leastly, María José Soler, our speaker of today. And she's a lady known for many years being an onconephrologist. She's, well, almost all her life, she lives in Barcelona, works in Barcelona, and care of the patients in Barcelona with a short period of time of spent as a postdoc fellow in US. But from the perspective of onconephrology, she started also several clinical trials, several other major research in onconephrology, publishing many papers. Now she is leading the European-based trial of nephrotoxic effects of ICI. And it's really our pleasure and privilege to have her as a speaker today. And also, I would like to tell that this is a live session, and ERA is offering a real-time translation of audio and captions with artificial intelligence in 7 languages: French, German, Italian, Portuguese, Russian, Spanish, and Turkish. To enable the audio, click on the globe icon at the bottom near the pulse function and choose your language. For the captions, an external link to access through the browser will be provided within the chat. And also, by participating live, participants will earn 1 European credit for their continuous medical education. This is an exclusive benefit for active ERA members only. To get the diploma, attendees must fill the mandatory questionnaire feedback at the end of the e-seminar. And now it's time to start. And honestly, Maria, the floor is yours. And we would like to listen and would like then to ask you several questions, because this is a really very hot topic and of interest of nephrologists, internal medicine physicians, transplant physicians, medical oncologists, and I'm sure for many others as well. We have some kind of questions which were posed previously, and also we encourage people to put their questions in a chat to make our discussion much more vivid and really to exchange our experiences in this field. Thank you so much, Maria. The floor is yours.
Thank you very much. Thank you. I would like to thank the working group of the acute kidney injury of ERA for inviting me. And today I feel with friends that I collaborate with Dr. Shruti Gupta, with you, Jolanta, and I'm happy to be here sharing our small experience in onconephrology, because actually it's a field that we started to work together, Jolanta, and the first time that I almost heard about onconephrology was a meeting that you were studying back in Vienna in 2019. So let's go, and I will try to talk also a little bit about the history of onconephrology, the history that is a new field I'm feeling, but that will be greatly developed. These are my disclosure, my conflict of interest. I will start by an introduction, clinical case. I need that this is the first patient that wake me up about this field, and I would like to share with you mortality in acute kidney injury in persons with cancer. Where are now the guidelines? Do we have a good guidelines, or do we need more? Where are we going, and conclusions? So before the era of the new drugs, persons with cancer and metastasis, they die early. So at that time, when I started nephrology a few years ago, no, just kidding, a lot of years ago, when a patient with cancer and metastasis came to visit me, I was even thinking about performing a kidney biopsy. But after, this is a slide from Monica Bolufer thesis, but to show you the development of new drugs in the last year. In 2011, 2018, a Nobel Prize was given to the people that invented the immunotherapy checkpoints, and this has changed a lot. And this changed to that way that now we are in the era that people with cancer and metastasis, they have chronic disease. They will not for sure die. And I think that currently the people taking care of cancer, they do not know the prognosis, the survival prognosis of their patients, their oncology, because they changed that much that they have become chronic patients, like patients with chronic kidney disease. So what are the causes of kidney injury in patients with cancer? So specific cancer factors, such as factors that affect our kidney, acute kidney injury in the setting of drugs, of obstructions, chronic kidney disease, factors related to cancer treatment. So as you well know for sure, some of the treatments that we are giving for cancer, they have nephrotoxicity. For example, the classical cisplatin, but not only the classical cisplatin. We know now that the new drugs may also have cancer toxicity, and some factors already related to the patients. What factors have been identified as independent risk factors for kidney disease in patients with chronic kidney disease? Age older than 66 years, hypovolemia, history of chronic kidney disease, patients with diabetes, sepsis, ACE inhibitors, renal angiotensin blockade, and the excess of depletive treatment. If we go to what is the cause of acute kidney injury in the patients with cancer and metastasis, so the cause is the same that we have in normal patients that have an acute kidney injury. We should check for the pre-renal status, functional volume depletion, arterial hypotension, vascular compression, and cachexia. We should know if our patient has a post-renal acute kidney injury. For that, we have the echography that could help us to know if the patient has a lithiasis, an acute urine retention, or some compressive process. For example, the same cancer can have a compression at the urinary level. And we also have the classical renal parenchyma disease, such as glomerular, tubointerstitial, and renovascular disease. And for diagnosing that, we need kidney biopsy. I will try to discuss later on when we should perform kidney biopsy, because a lot of people already asked, or doctors, nephrologists already asked for that in our chat. So what will kidney biopsy give to us? Kidney biopsy will give us the renal histopathology in the patients with cancer, the kidney pathology, and with that will give us the possibility to treat, not to treat, and to do a target therapy to our onconephrology patient. This is the consensus that I was talking previously, and I have the opportunity to participate. I was like Jolanta, Małyszko, and Camilo Porta, that were the organizers of this consensus. And this consensus was held in 2019, and 2 papers were published in KDIGO. And at that time, it was the team decided that the patients that needed kidney biopsy were the patients with proteinuria higher than 1 gram. We can discuss now, because at that time, immunotherapy and checkpoint inhibitors were not that developed. So we can discuss later on. This was the result of the consensus. Worsening renal function without clear cause that might change clinical management, and it was commented and discussed clearly to avoid in patients with poor prognosis. So if you are thinking that your patient will be dead in 1 month, there is no sense. So for that reason, we also have an expert in palliative care in patients with acute kidney injury today in our panel. And in which case of patient with glomerular disease we should screen for cancer? In patients with adult patients with minimal change nephropathy, and in patients with membranous glomerulonephritis over than 60 years. So I was telling that this was a long time ago, and we do not have now a clear consensus telling us when should we biopsy these patients. This was recently published this August, 1 month ago, in Kidney and Blood Pressure Research. And this team, mainly from Italy, proposed these indications, but we can later on discuss if we agree or not agree with these indications. Delay recovery of renal function after treatment with this drug, known as a cause of acute tubular necrosis, cisplatin, carboplatin, and the others. Acute kidney disease in patients treated with immunotherapy without rapid improvement after glucocorticoid treatment. At that point, I'm not clear. We can discuss and we can talk about that, because some patients with immunotherapy, they have acute tubular necrosis and they do not need the treatment they do not need to be treated currently with steroids. So maybe if this patient has a long expectancy of life, it's better to perform a kidney biopsy and know if we need to treat or not this patient with steroids. Or in the future, I will try to propose some kind of strategies that may help us without kidney biopsy to have a high suspicion of acute kidney disease related to immunotherapy. Acute kidney disease patients treated with immunotherapy, we have seen signs of glomerular damage. You all know that, and I will not go through this. Patients with multiple myeloma, patients with MGUS, patients with acute kidney disease and with exposure to nephrotoxic drugs without evidence of pre-renal and post-renal causes, acute kidney disease with glomerular hematuria or proteinuria, and some of electrolyte disorders, and we can also discuss about that later on. Let me go to the clinical case. This was the first patient. This was a woman, 59 years old. It was the 2018. So early on when people were starting with immunotherapy, expanding this, not only in the clinical trials, but in the daily clinical setting. This was a woman with metastatic neuroendocrine lung tumor and that was treated first-line therapy, lanteotride, disease progression. Second-line, axitinib, poor response. Third-line, everolimus, progression. And as a fourth-line, the patient started a combination with a monotherapy in the clinical trial, durvalumab and tremelimumab. 4 months later, she developed acute kidney injury. She came with serum creatinine 3.5. The baseline was normal. Protein to creatinine ratio 680 milligrams per gram, a little bit of hematuria, and the patient explained that she was feeling really bad and having a lot of diarrhea. And we, by that, at that moment, this was a mistake, but in life, you should explain the good and bad clinical experience that you have. And it was attributed to pre-renal acute kidney injury etiology. We treated the patient with intravenous hydration, and immunotherapy was discontinued. And 4 or 5 days later, the patient has a creatinine 1.5, almost normal, not normal, but almost normal. And we decided to discharge the patient, and durvalumab or monotherapy was reinitiated. What happened with this patient? 2 weeks later, she developed acute renal failure again. And what did we did at that moment to this patient? Patient was creatinine 4 milligrams deciliters, again, 1 month later of the new checkpoint inhibitor, hematuria, higher proteinuria, and eosinophils in the urine were increased. And the patient developed metabolic acidosis. So at that time we were thinking this could not be a pre-renal. We started to look at the literature, PubMed, what's going on with this patient, and what was our next step. Our next step was to perform a kidney biopsy. And this was published in one of our first series in Clinical Kidney Journal in 2020. And the patient has acute tubular necrosis for sure, but also acute interstitial nephritis. What did we do? We treat the patient with prednisone, stop immunotherapy, and 1 week later, we again discharged the patient with creatinine 1.6, and 2 years later, she's alive because we have new therapies, and she's alive. She keeps being alive, and the creatinine was normal. So clearly, we here were in a case of patient that develop acute kidney injury associated to the checkpoint inhibitors. So we decided to review all of the patients for 1 year and a half that in our institution were introduced with immunotherapy. And this was published in NDT with Dr. Clara Garcia Carro, and this was also the part of the thesis that we are proud of because it was our first onconephrology thesis in our department. We reviewed 821 patients, and from them, 15% present acute kidney injury, and the survival rate was only half of them. A few, as you can see here. What were the risk factors that we found for mortality in these patients? So patients that develop acute kidney injury in the setting of cancer and immunotherapy treatment have higher mortality. And this was clearly not only in the Kaplan-Meier, as you can see in the right of the screen, this is also clearly shown in the multivariate Cox analysis. These patients clearly develop had higher mortality. And we start to think, is for the acute kidney injury per se, that worsens the prognosis of the patients. Actually, we already know that when one patient is admitted to the intensive care unit and develop acute kidney injury, this patient has higher rate of mortality, is at risk of mortality. And with COVID-19, we learn a lot about acute kidney injury and intensive care units, and the patients that was with COVID-19 in an intensive care unit, they have almost 50% the probability of mortality. But in that case, we were withdrawn the immunotherapy. So is the withdrawing of the immunotherapy and the not possibility of treating these patients with cancer that was increasing the mortality? Maybe. From this study, I cannot answer this. So going through the other way around, I just found this paper published that is really nice. That is, let us study the recovery of kidney function and the mortality after acute kidney disease, and which risk factors increase the risk of non-recovering and the risk of death. This is a nice study that participate 464,000 of patients from 3 different countries and 4 different hospitals, and these patients develop acute kidney injury. And as you can see here on the right side, the patients that have increased risk of death were male, elderly, as expected for sure, patients with heart failure, and patients with cancer. So if you have cancer and develop acute kidney injury, you are the patient at risk for death. Why? For sure, one of the reasons may be related to the withdrawal of the cancer therapy. So it is crucial to diagnose the cause of the acute kidney injury if you can treat the cause and if the patient could be rechallenged or retreated, in my opinion. This is my opinion. Going through the same, in our group studied the acute kidney injury in patients that were treated with CAR T-cell therapy and hematological malignancies, but you know that CAR T-cell therapy now is going to spread to other kind of disease. So from 115 patients, we found that 24 patients develop acute kidney injury. We are talking about 21% of our patients, and the independent risk factors in this case for developing acute kidney injury was male sex, chronic kidney disease, have neurology affection, and have icons, and a cytokine release syndrome, as it was expected and published by other groups. And the interesting thing is that the patients that develop acute kidney injury, again, have much mortality, but in that case, we were happy because this kind of acute kidney injury, in the majority of the patients, 79%, it was a work performed with Juan Leon from my institution, the majority of the patients recovered kidney function, indicating that this was a kind of transient. If we go to where are now the guidelines, what should I deal with my patient? With Doctora Bermejo, we published with Sheila Bermejo, that is one of the attendants that is working with me, and she takes care of the Onconephrology clinics. We write this review about the ASCO guidelines. And with this review, these guidelines are mainly written by oncologists. So oncologists do not call the nephrology each time that they have an acute kidney injury, but I think that they could call a little bit more, because they decided that the kidney biopsy should be performed in patients with proteinuria higher than 1 gram, in patients with severe creatinine, but we published in CKJ that immunotherapy could increase only a little bit the creatinine, and we are seeing this in our daily clinical practice, that the patient with creatinine from 1 to 1.8 is developing an acute kidney injury associated to immunotherapy, and patients with really high increase of creatinine. With Ben Sprangers, we participate in this Nature Reviews Nephrology, and here we state the patients with acute kidney injury, degree 2 or 3, should be biopsied, and the stage 1 trying to treat the cause and depend in the type of if the patient improves, only withdrawing the treatment or continue the treatment. What about the nephrology? In nephrology, we have also an onconephrology working group. What did our group, what we decided to say? In acute kidney injury degree 2 and 3, if there is not contraindication, we biopsy all of the patients, and acute kidney injury degree 1, it depends. We propose to individualize. And this is interesting because you can have somehow the suspicion, because you know that acute kidney injury should be only not the secondary adverse effect of checkpoint inhibitors, for example. This could be associated with another disease like gastrointestinal and several of them. What about update? Which kind of drugs and what's the pathology of which different drugs could do? For example, you all know this. We made this kind of revision with Dr. Garcia Caro, and we show that patients with we know, and there is a lot of literature published, patients with thrombotic microangiopathy could be for platinum, missing, anti-VEGF, tyrosine kinase inhibitors, I will not read all of them, focal and segmental glomerulosclerosis, minimal change disease, lupus nephritis. So not only these drugs will cause acute tubulointerstitial nephritis, if not other diseases, how you can see here. I would like to present this study. This study was recently published in 2020, and this was part of the thesis of Dr. Monica Bolufer. And this look at the mirror or at the window through the other way. We go to look at the patients of kidney biopsy performed in Spain with cancer. What was how were they, and what was the diagnosis, and why we decide to biopsy these patients. This was a study from 12 centers from all around Spain that participate the Onconephrology group and the group of glomerular diseases, for the working group of glomerular diseases from Spain. And this was performed, they were the biopsies performed from 2010 to 2021. A total of 148 patients were enrolled in the study. 15% of the patients have a creatinine at the moment of the kidney biopsy higher than 1.5. Here you can see the type of cancer. The most frequent biopsy cancer was lung cancer, followed by gastrointestinal, renal cancer, as you can see here. The median creatinine was 2.58, and the protein to creatinine ratio 700. 53% of the patients have hematuria, 31% of the patients have leukocyturia, and nephrotic range proteinuria, 23% of the patients. Here you can see the therapies of the patients: chemotherapy, 28%, checkpoint inhibitors, 29%, the majority, because we already have the last year's patients. So you have the cancer diagnosis, and 67% of the patients were biopsy. The indication of the kidney biopsy was for acute kidney injury. The majority of them degree 1, and followed by degree 3 and degree 2. And here you have the results of the biopsy. The majority of the patients have, as expected, acute interstitial nephritis, followed by acute tubular necrosis, IgA nephropathy, some of them glomerulonephritis. But one of our questions was, has changed in the last year the scope of these biopsy patients? Have this changed? So we decided, we talked with Monica, let's go take first the 6 years and the 6 years later, and let us take a look. Really important, we found that, as you can see, few of the patients we treated with immunotherapy because they were in the clinical trials and they were starting immunotherapy between 2010 and 2016, but the majority of the patients that were biopsied from 2017 to 2021 were related to immunotherapy. And what was the diagnosis of the renal injury? Part of them, almost 1/3 of the patients, have acute interstitial nephritis at the first decade, but after that, at the last years, almost half of the patients. And this is a really interesting thing for us. What are we going now? What's the goal? What do we now want to go with this, with the patients? We want to improve survival and quality of life of patients with cancer and metastasis in acute kidney injury, for sure. And I think that for that kind of patients is the moment to personalize medicine. It's not bread for everybody. So we should look at the patient, diagnose properly if the patient has a higher or low suspicion, and decide how to go with this patient. In that sense, this is a nice paper published in Kidney International Reports, published by my friend Sandra Herman, trying to decipher what patients with immunotherapy, they have acute kidney injury related or not to immunotherapy. Why? Because when they clap to my door, María, should I continue with immunotherapy in this patient? If the acute kidney injury is for gastroenterity, for diarrhea, you can continue for sure. And if the acute kidney injury is related to immunotherapy, maybe we can continue, but with a different strategy. And in their group, they compare 37 patients with 13 patients. And in their group, they found an increased creatinine level. This was not in our case, but maybe they are a referral center for over America. And it's different because in our hospital, we manage more with our patients. Maybe that was the case. And the important thing is that the urinary retinol binding protein was in the urine with the ratio of the creatinine was clearly higher, and the protein C reactive was also higher, much more higher in patients with acute kidney injury related to immunotherapy. So maybe this could in a future become a market. So when you have a patient with a cancer, immunotherapy, a normal C-reactive protein, a normal urine retinol binding protein, maybe you have a low possibility of having acute kidney injury related immunotherapy, and this patient could be nicely retreated. Another study, thanks to Professor Gupta, that is today in the panel, maybe she can explain a little bit more. She chose the patients that from the working group of acute kidney injury related to immunotherapy that have a PET imaging, and they found that the image in the renal of the patients that have acute kidney injury related to immunotherapy was, as you can see here, nicely increased. This was recently published in Journal of Clinical Investigation. So maybe in the future, we should go for a PET imaging. We should go for Professor Herman proposed markers, and it will not be needed a kidney biopsy. When do we propose to rechallenge the patient? When, for sure, when the patient has not a life-threatening ERAE, for sure, you could retreat, and when the patient has a life-threatening ERAE, in this case, we will not recommend. The other question that we have with Professor Gupta was, how long should we treat these patients with steroids, with high doses of steroids? For 3 months, for 2 months, for 6 months? Actually, for having the answer of that, for sure, we need a randomized clinical trial that we here do not have. But at least if we have a large cohort, we can try to answer this. So with the 429 patients, we included 165, 56 with a shorter duration of high-dose corticosteroids and 109 with a longer duration. And it means that these patients with a shorter duration, at 24 days, they were under 10 milligrams of prednisone. We didn't find difference in terms of acute kidney injury, recurrent, or death, suggesting that with 28 days of high dose of prednisone, it might be enough. What is needed for sure? This is needed a multidisciplinary treatment, because we are nobody's alone in the world, and we need to talk and to have a close relationship with the oncologists, hematologists, urologists, and the people that take care of these patients. As Dr. Jolanta said, we are now in a European project that it participates 6 countries asserting new biomarkers in patients with immunotherapy. And as a conclusion, early diagnosis of acute kidney injury in patients with cancer is needed. I think that we should individualize renal biopsy. Patients with cancer and acute kidney disease should be diagnosed and treated to avoid chronic kidney disease. We need to develop and establish urinary and blood biomarkers for treatment of these patients. Onconephrology multidisciplinary units are the clue. There is an urgent need for randomized clinical trials. And in the future, if I could dream today, more studies are needed, multicenter studies, randomized clinical trials for these patients, more consensus and guidelines that I think that are coming now, need urine and blood biomarkers, implement fellowship in onconephrology. This is already established in America, but in Europe, we are behind America on that. And thank you very much for your attention.
Thank you very much, Maria. Thank you very much, Maria. It was really excellent overview of the new advances. And now it's time for our panelist. Who will go first?
Happy to go first. Yeah, that was a great talk, Maria. It's very nice to see your work and everyone else's work highlighted so nicely. This is an area I think that there's been a lot more research on over the last 5 to 10 years. And I think the next step is really trying to understand some of the mechanisms so that we can also think about how to treat these patients better and develop more targeted therapies. I tried to answer some of the questions as they were coming in the chat. I think one of the questions that was raised just now is a patient who's on combination therapy, and whether that patient, particularly if they're reluctant to undergo a biopsy, whether they should be treated empirically with corticosteroids. And my short answer is that patients who are on combination therapy should usually get a biopsy. We're seeing a lot more patients who are getting a variety of different combination therapies, whether that's with, platins and immunotherapy. We see patients on VEGF inhibitors and tyrosine kinase inhibitors and immune checkpoint inhibitors. And I think it's really difficult to differentiate the cause of AKI. And as Maria and our group and others have shown, there's no clinical features that are sensitive or specific for the diagnosis of ICI-AKI, which is why I think particularly when patients are getting combination therapy, we should think about biopsying early. That being said, we shouldn't delay corticosteroid therapy in a patient where we do have high suspicion for ICI-AKI because we know that early treatment with steroids leads to renal recovery. There was also a question about transplants and ICI-AKI, and again, the short answer for patients with transplants is, they're a very complex population, and there are a lot of people who are doing some good work in this area. But we do know that patients have high rates of rejection, like 30 to 40% of patients who have kidney transplants and get ICIs have rejection. And there are some newer strategies that are being trialed with good success, like use of mTOR inhibitors and steroids in combination prophylactically in patients getting ICIs, and those patients have preliminarily been shown to have lower rates of rejection. And then finally, I think there was a question about infliximab and other therapies, and I think that this is a really important area. And I know our group in the US, we're hoping to get some funding to actually do a large clinical trial where we actually test some of these second-line therapies as maybe even upfront therapies for ICI-AKI as steroid-sparing agents, because we know that these patients, often develop nasty side effects from steroids. We know that there's some data that steroids may actually blunt the immune response. And so I think there's a lot of interest in trying to see whether some of these alternate therapies lead to similar rates of kidney recovery and also allow people to get back on their, life-saving immunotherapy sooner. Sorry, and then the last thing I'll say is PET scans. Yes, this is, I think, a really important area. I think there's been a lot of focus on blood and urinary-based biomarkers, but radiological biomarkers, I think, are another really important sort of next step that we should be thinking about. We found in our JCI paper that Maria mentioned that patients with ICI-AKI, they have preferentially increased uptake from their baseline scans to the scans at the time of AKI compared to patients that have AKI from other causes. So I think that that's really important because, our patients are getting PET scans not infrequently. So if we can actually have radiologists look at their PET scans at baseline and at the time of AKI, and we see increased uptake, then that might be enough, to basically make the diagnosis. But I think we do need some larger prospective studies to verify those findings.
Thank you so much, and Victoria.
Yes, so I think I might be one of the very few intensivists in this webinar. And again, thank you very much for inviting me. So I think my take in all of this, and I guess a question that I would pose to our listeners, but also to Maria and Shruti, is all this is well and good, and there is clearly amazing progress in this area. But then what happens if one of these patients ends up in multi-organ failure in intensive care? And then, so let's say that we do have a cancer patient that ends up in multi-organ failure in intensive care, and a part of this multi-organ failure then is the AKI. So I'm describing, which is quite common. I think, Maria, you mentioned that intensive care, AKI in intensive care, it definitely is associated, not always, but I think it's associated definitely with worse prognosis. I think my question to you and the audience is, all this evidence, how transferable is it in someone when they're in intensive care?
It's the million question, baby, but not only for that. Actually, not only for oncology. Actually, I launched the question, how many of you have performed a kidney biopsy in the intensive care unit? We've done here, but we are a large center, and we have a experience of 20 patients or something like that, because this patient have a really severe condition once they are with you. and the risk of bleeding is really, really high. So imagine, not without cancer. If you include cancer and they are with a multi-organic disease, if you think that the multi-organic disease is associated with the kidney injury, for example, put in mind thrombotic microangiopathy, maybe is the only case where I will go for biopsy if the platelet is okay. But maybe it will be the only case. And when I think that the patient has a future of recovering, for sure, more than 2 months of life, and when I can offer something to the patient, not only for diagnosis.
I think, yeah, Shruti, I would really be keen to see what you're saying, but I think you've touched something there, Maria, because I think the majority, or yeah, some of the intensivists were not really very good in diagnosing or differential diagnosis of what is this AKI. And as we've heard about steroids in ICI, and we've heard about, PET scans, and you talked about biopsy, I am not sure 100% how all of this is transferable in the ICU patient. Should we be doing all this when the patient is in ICU? Apart from, as you say, the very, very few and apart cases where actually doing the biopsy and not giving, for example, blind steroids might change the diagnosis. I'm only saying this because I find it very difficult, not just with oncologists, as you say, and renal failure. There is not enough evidence for this subcategory of patients in intensive care. All these studies and the outcomes and the percentages are for, I guess, your generic patient that will come in your outpatient clinic. When they come into ITU, this is probably something different. We do have sometimes difficulty in relating with the specialties, but Shruti, I'd be interested to see what you think as well.
Actually, my nephrologist team, one of them is going every day to the intensive care unit. So you have to have friends, nephrologists, and your consultant that is close to you, because this is we work that manner here. We are one of the biggest intensive care units in Spain. So we have the possibility to have 80 UC beds. That is a lot here in UC beds. That is a lot in Spain. So we are close. We have a continuous therapy, and we work together. It's not only, so maybe you need a close friend that works with you in the intensive care unit. I don't know your opinion, Jolanta.
Well, in general, we do have very good collaboration with our ICU, not only concerning the nephrology consultations, but also discussion concerning the type of kidney replacement therapy. Because in general, in ICU, I would say that the predominant mode is CRT. However, in our hospital, and we are also unique, we do have the hybrid techniques, like SLED using the Genius machines. So that's why from time to time, and we are discussing what is the better option, whether to put on CRT for 24 hours or 48 hours or so, or to use like hybrid techniques, like for 6, 8, or 12 hours. This is one point. What we did as well in collaboration with our ICU, it's like some patients with liver cancer awaiting the liver transplantation, or with cholangiocarcinoma. In hepatic phase, we tried high volume plasmapheresis to wait for the liver transplant. So that's why we are working very, very closely. This is one point. Another one point which I would like to touch, it comes from I would say, the ethical part. When we do have the patients with metastasis everywhere, is it the good candidate for ICU? This is one point. And it's usually, we have like a pressure from the family. And we try to make the conciliatory statement asking ICU people, nephrologists, medical oncologists, and the family, try to make the decision that if oncologists will not see the chances for any treatment, the patient is, well, let's say, rather not candidate for ICU. It's a candidate for end of life care or palliative care. This is the very emotional part of our work, and this is very difficult because we are dealing with patients, with the families, with I would say the huge expectations. And usually for us, the biggest discussion is whether the oncologist could give the I would say treatment with intention to slow the progression, not even to cure, but slow the progression. If there is nothing like that, the decision should be also made on the team-based, because otherwise, for me, in particular, when it's coming to the end of the week, and if we do have such patients in our ward, we're trying to, I would say, try to figure out how to manage, not to leave it to the doctors during the weekend, not to give in to the doctor on duty in the Friday weekend. This is the toughest part of our work. I don't know, Victoria, what's your opinion? What's your suggestion? But in generally, for all of us, because, well, I'm not just joking, but in the nephrology department right now, it's like we have like oncohematology subunit. Because in general, in the medical oncology, they do the treatment in the oncology ward, but the diagnosis and the treatment of the complications are generally outside oncology. And we are like, would say, the most beloved ward to treat these patients or so. Fortunately, we do have the residents who are doing the internal part of the medical oncology in our ward. So we are just stressing what's underlying that for them, it's a whole oncology diagnosis. They're going to oncology to see the treatment, and they're coming back to nephrology to see all the possible complications, including palliative care and end of life care.
Yeah, so I think that's a very good question, Jolanta, and I don't think there is a unified answer, because I'm pretty sure that Shruti in the US will say something completely different that you will say in Central Europe, that people will say in Northern Europe than in Southern Europe. I think this is, I think we do tend to believe that sometimes ethics is one thing and there's one right decision for everybody. I don't think that exists, and ethics can never be separate than the legal framework. And it is very different. For example, I'm in the UK, I practice in the UK. There's a very clear legal framework about providing treatment that you as a specialist don't think will be appropriate, let's say. If you lack this framework, then people will have to come to intensive care if the patient says so, if the family demands so, whether the clinician thinks that is appropriate / ethical or not. I think these are very frustrating things. These things definitely lead to burnout for the people that that look after these patients. I think my suggestion would be to always think that in specialties like yours, like mine, that we treat people that there's risk for their lives, that approaching the end of their lives, that it should not be just therapeutic, it should also be palliative, whether you have palliative not in the sense of end of life, but palliative in the sense of supportive. So these people, their families, their symptoms, spiritual, they're a whole. I see there are many questions, Jolanta, in the chat. So I'll let you ask.
I'm surprised because, sorry, but in Spain, the intensive care medical doctors decide if you need or do not need, and if you will have a benefit under their experience. No, this is the normal way of working here.
But not always, but not everywhere, Maria.
No,
not everywhere.
Sometimes you could have problems because some families, for sure, they say, no, my father's, I understand the point in UK, but it surprised to me to listen at that. And I don't know if it may be for the constraint of intensive care unit beds, because As I'm aware, for example, in Germany, they have a lot of intensive care unit beds. So we have here intensive care and a kind of semi that are smaller ones without mechanical intubation. You know, this is another surprise to me. It's nice to have this kind of conversation.
And we still have some time, and there are still a lot of questions in the chat. If there is anyone who would like to answer the question concerning, do you have any experience in steroid-resistant immune checkpoint inhibitors associated AKI?
Yes, we see quite a bit of it, and we're using infliximab more, and there's interest in tocilizumab. I haven't found MMF to be particularly helpful, so I don't really use that in my practice. But usually, if a patient completes a course of steroids and they develop recurrent AKI, I actually try to avoid giving them a second course of steroids and instead trial some of these other agents quicker than I used to.
There's also a question concerning pediatric part. What is the state of art about kidney biopsy in onco children with AKI? I think we need to ask the pediatrician.
I am sorry. I'm not pediatrician. We have a really good children hospital here, and we have a joining session each week with the pathology in the pathologist department for checking on the kidney biopsy. And until now, I've not seen any biopsy in children with cancer. And
there is another one question.
Personal experience, but I could ask them for sure. We could ask and maybe answer.
And there is another one question. Any data of preferred renal replacement therapy modality in patients with cancer, hemo versus PD?
This is a really good and difficult question. I think that it depends in the type of cancer, because if, for example, you have a gastrointestinal cancer with a surgery starting from here to here, I will not go for PD. But in another type of cancer without surgery and without metastasis at the intestine level or the peritoneum, could be a good option, because actually it's comfortable to do this kind of PD.
Well, for me, it's generally two questions. What is completely one? First of all, is whether there is a patient with a history of cancer. So, well, it doesn't matter whether hemo or PD. This is one point. Whether there is, I would say, the treatment with radiotherapy, I would rather avoid PD. Because of all these problems later on with fibrosis, retroperitoneal fibrosis, etc., in particular dealing with the prostate cancer or gynecological cancer requiring radiotherapy. However, concerning the use of hemodialysis, what we did in our center with the collaboration with oncologists, when we do have the patients on dialysis, like on hemo, we can adjust the treatment, the oncology treatment, to the time of hemodialysis. Like with patients with a lung cancer treated with bleomycin and etoposide, we perform the hemodialysis just after the chemotherapy to take out the active metabolites. And we have like series of some patients we worked together trying to adjust the modality. So that's why I think it's a little bit much more complicated. In general, I would divide into two parts: history of cancer, current treatment, and it's particularly important because also some drugs, they should not be given before dialysis, not to be eliminated. Some of them should be, the hemodialysis should be started just after, etc. So I think it's much more complicated, and it's it's difficult to answer within a few minutes left for the rest.
And we need that the oncologists include our patients in hemodialysis, in DP, in the randomized clinical trials, because we do not know, sorry, but I had to say that, how to dosify these treatments to our patients. So a call of action?
Honestly, Maria, with the Australia and New Zealand medical oncologists, there was a guidelines which were developed looking at all the available literature concerning CKD stage 1 to 4 and the treatment and the drug dosing. It took us quite a long time. It's published on a website, and still CKD stage 5 and patients on PD or chemo are awaiting to look for this particular treatment, which drug we can use, which we cannot use, etc. However, because time is running so fast, first of all, I would like I would say the woman team today, which is very unusual for the webinars, honestly, because we gathered people from all over the world. I mean, Europe and US, with great expertise. We would like, first of all, to thank our audience, because they kept us busy till the very last moment. We do apologize. We could not answer all these questions very, very thoroughly in all the details. However, the session was recorded. It will be available. And also it will be available on the ERA website. And the people, I'm sure they're also free to put the questions, the remarks, and suggestions, because the topic is really very, very hot for today, and all of us, we do learn. And in particular, all these, I would say, the multidisciplinary teams and the discussions, well, at least I do hope for all of us are much more fruitful than just to put a speaker and dealing with just the presentation of the knowledge. So once again, thank you very much, and I wish you all of you a very nice evening, or like in US, the very nice day.